So I'm Dr. Diane Tucker. I'm a psychologist with the Supportive Care Clinic at UAB. I'm excited to be part of the Psychosocial Oncology Training Academy. And we today have Dr. Cynthia Ryan with us. Dr. Ryan is a faculty member in Department of English, and her specialty is rhetoric and specifically scientific communication. So she speaks to us both as a breast cancer survivor and as someone who thinks a lot about how to communicate about topics like breast cancer to a very wide audience. So Dr. Ryan, thank you for being here. If you could talk with us a little bit about your experience with breast cancer, and then we'll talk further about, kind of how that's continued to impact you over time.
Okay. So I have experienced breast cancer twice. I was diagnosed in 1993 at age 29 with triple negative breast cancer. And then in 2004, I was diagnosed again with this time estrogen receptor positive breast cancer. Both times stage 1, both times the response was mastectomy followed by chemotherapy. And I was thinking to myself on the way here today that actually I'm 57 years old right now. So I'm almost to the point where half of my life will have been spent as a breast cancer survivor. And that's kind of mind-blowing when you think about it. So
it's not an identity most people have. Most people couldn't say anything close to that at your stage in life.
Right. Yeah, I think that's true. And I'm incredibly fortunate because at the time I was diagnosed with triple negative at 29, there wasn't all of the research that we currently have about how the disparate outcomes with triple negative. Triple negative is one of the most aggressive types of breast cancer. It usually strikes young women. I've met and worked with several women who have been diagnosed with triple negative, and they have not necessarily had the same good outcome that I had. So I've been fortunate, really fortunate.
How was the breast cancer picked up the first time? That's early to be
right.
attending.
It was just, I just found it accidentally. So I was sitting on the couch and I just put my hand up. I don't know, I even remember why I was putting my hand up, and just kind of laid it on my chest, and I felt something. And at first I thought that I had accidentally gotten something into my shirt, that there was something in there. And then I realized it was a lump, a really hard lump. So I immediately knew it was something. I didn't know anything about breast cancer, in all honesty, but I knew that it was something that wasn't normal. I did breast self-exams at that time every month. I had never felt anything before. So the next morning I was in a surgeon's office, and he was examining it, and initially told me that he thought it was just a cyst, and I should go away and come back a few months later. And I said, actually, that's not what we're going to do. What we're going to do is get this examined. And within about 2 days, I knew that the cells were abnormal. And about a week later, after a few more consultations, I had a mastectomy and started chemo, and my life changed forever. That's an interesting question, because I think that I know that the audience for this is largely going to be people who practice medicine and who see people like me. And I think that one message I have tried to communicate in my writing and in my public speaking is that everything changes when you're diagnosed with cancer. I think that in so many ways, the experience is not about cancer. And I think that that gets missed a lot. So for example, the first way that my life changed is that there's an incredible sense of loneliness and isolation you feel when you're diagnosed, especially when you're diagnosed at 29. We're surrounded by messages that suggest the status quo is health and happiness. And suddenly, you're not living in that world anymore, especially with people your own age who, from my perspective, didn't have a care in the world. When I went to support groups to try to kind of try that avenue to have some kind of emotional foundation, the women were much older than me. They couldn't relate to me. I wasn't really in a relationship. I had started dating someone who's now my husband, but I wasn't married. I didn't have really my own family to cling to. Physically, I lost a breast at 29 and did not have reconstruction until the second bout of cancer. And at that time I had reconstruction. But physically, I looked different. When I started having chemo, because it was a triple negative diagnosis, I got the hard stuff. I got adriamycin, which is known as the red devil, and my hair fell out. So I'm trying to go to graduate school, trying to go to classes, and my hair is falling out. So I wore a baseball cap, and it changed everything. I mean, it changed what I studied. It was the summer after my first full year in a graduate program, a PhD program, and all of my research and all of my work shifted almost overnight towards examining messages that are communicated both in the medical environment and also in the media. And it changed everything. There's not to wax scholarly here, but there's a very well-known medical sociologist. He's Canadian. His name is Arthur Frank, and I love his work. And what he says is that, again, this whole idea that the status quo narrative in this culture, biomedical model, is that we're healthy and we're happy, and that if something does happen to us, we will be restored. So he talks about the restitution narrative. And the idea of the restitution narrative is what you see in any advertisement for any medication. You have a cold today, take the medicine, the cold medicine, and in a couple of days you'll be back to where you were. That doesn't happen after a cancer diagnosis or any major diagnosis of a disease that's going to change your life forever. There is no going back. And that, I think, if I had to say that is the one enduring change, it's that after a diagnosis of cancer, and I've heard other cancer survivors say this as well, you're never carefree again. You're never that sort of, I can take on the world and nothing will hurt me, and at the end of the day I'll be okay, because you receive the diagnosis. You hear the words, you have cancer, you're told the odds of survival. Your life is just never the same again. No. Absolutely. Absolutely. Yeah, I think that, one thing I have devoted my life to after that first diagnosis is helping people learn how to advocate for themselves or being an advocate alongside them. So, for example, I work a lot with women in the community who are homeless, who are also experiencing cancer. And it's not that they can't advocate for themselves or they can't say what they need or what they're thinking. It's that a lot of times people don't listen to them. So I've been in, exam rooms and in, pre-op settings where a friend who happens to be very poor on the streets, oftentimes African American, is met with deaf ears. I mean, a physician will walk right by her or not really listen to what she's saying, especially when it pertains to the pain she might be feeling. So I've spent a lot of time trying to help individuals understand how important it is that they advocate for themselves and advocate for people who need help, voicing their concerns. I think that's really important. One thing, there's been a lot of debate about breast self-exam and whether it's useful. And what I always tell women is, the data is mixed, the research findings are mixed, but the one thing BSE does is it validates your authority, because the whole idea behind breast self-examination is for you to detect what's different in your body. So from that perspective, whether or not it changes the odds of, survival, that's debatable. But at the very least, it means that you become familiar with your body and you're the voice. And that's why I knew at 29, when I went to the physician said, you can come back in a few months. I said, this wasn't here, or I didn't feel this a month or two ago. So I'm not waiting a few months. You're gonna do something now. So I will say doctors often don't like me, and I don't really care, because I think that, you have, it's your body, it's your life, you have to advocate for yourself. And so if a doctor is, or any healthcare worker or a friend or a family member is trying to tell you that your instincts are not to be validated, or that you just need to be patient, I say no. You do what you know is right based on your instincts and your experience with your own body.
And I wonder if that does also extend to when the restitution narrative is applied for someone, where they feel differently after the experience of cancer, and it could be partly side effects of chemotherapy, but it also can be the changes in self-concept that
Sure.
happen through the whole treatment experience. And as the individual, you are the one who says, this is how I feel, this is how it has affected my relationships. And one of the audiences for these interviews are mental health professionals who are survivors of breast cancer, and maybe physically, cleaned up health, but still it is part of who they are and part of what they bring.
Right. Yeah, absolutely. I mean, this whole notion of snap out of it, it reminds me of when you lose someone, when someone passes away, and you're told, well, most people go through these stages, and at the end of, I was told when my father passed away, 1 year, you're supposed to start, once you've gone through all of the kind of anniversaries and milestones of the year, you'll start feeling better. Well, I found that the second year was far harder for me. So I don't like this kind of one size fits all, but I think that is, again, it's important to validate and listen to the experience the individual survivor is sharing. And it goes on for years. For example, my first cancer was in 1993. In 1997, I became pregnant with my oldest daughter. And this is unfathomable to most physicians, but one of the most horrible experiences of pregnancy was that I was very, very thin, thinner than I am now. And as my stomach grew, the scar stretched. The pain was unbelievable. So I would be in the obstetrician's office, and they were trying to come up with all kinds of ideas for like things I could wear to try to hold my stomach up. I had to have heating pads and pillows behind my back, and those kinds of things, they remind you continuously of the identity of cancer. Another example would be that with adriamycin, very, very common, I had horrific mouth sores. I had thrush, basically. So after a treatment, usually about 6 to 7 days later, my mouth would be filled with mouth sores. To this day, it's been what, 1993, it's now 2021. If I get a mouth sore, psychologically, I go right back there. And even physically, sometimes it will spread through my mouth. I know I'm not supposed to eat potato chips, but if I eat a potato chip and don't brush my teeth, I'll get a mouth sore. And it's because it broke down the lining of my mouth. So I think that psychologically and physically, and we're learning more about this in the research, that chemotherapy or radiation or even surgery is doing damage to your body. Those effects, while they may be life-saving given the cancer, those effects are long-lasting, and they have to be acknowledged. One of my great passions, because I don't sit around and dwell on, oh, poor me, very often, but one of my great passions is traveling. But after having reconstructive surgery in 2004, my lower back hurts because many of my stomach muscles were removed. So when I'm out exploring the world, one of my favorite things to do, there's that little reminder of cancer. And it doesn't go away. Years later, it doesn't go away. So, yeah. It's a part of who you are. And I'm not sure I would change that. I mean, I know that sounds odd, but when I look back, I've told many people this, when I look back at my life, I often think how shallow it would have been had I not been diagnosed. Because it forced me, maybe because I was young and there wasn't a community of people my age, it forced me to reckon with what was happening and then to realize that I could do something with it. I remember my surgeon who performed the first mastectomy said to me, life gave you lemons here, big time lemons. I was the youngest patient he'd ever had with breast cancer. And he said, you can either, wallow in sorrow and, figure your life is over, or you can make lemonade. And I made lemonade. One of the first things I did, this is corny, I don't think you even know this, Diane. I wrote I got engaged the next summer. And I wrote a magazine article for Brides Magazine. And I addressed that, there were things about my wedding day that were going to be different than I ever anticipated. And I talked about, not having a breast and wearing a prosthesis and having to look for a dress that would accommodate that. And it sparked a passion in me for public rhetoric. So in addition to doing, scholarly work, I've become very active as a public writer in magazines and newspapers and as a public speaker. So I think, I wonder sometimes, what would I be writing about or teaching if this had not happened to me? Would I be looking at things like how to better write paragraphs in the freshman composition class? I guess that's important, but compared to what I think I'm able to do with the experiences that I went through, I think there's much more depth there. It's more important.
It's given you both a voice and many audiences.
Mm-hmm. Yeah, absolutely.
That's one of the things that distinguishes you from a lot of academics, is that you've chosen to not have your audience be only other academics, but
Right.
to look at how your experience and listening carefully to the experience of others can really make a difference.
Yeah. I think if we don't, what are we doing? I've never, I grew up in a family, my dad in particular was very much an advocate. I grew up on a farm in Illinois, and he was the guy who was in Washington talking to the senators about what needed to happen for corn prices in the Midwest. And so I kind of grew up with that model. My parents were very active in the Catholic Church and did a lot of outreach and that sort of thing. But in some ways, the older I've gotten and the longer I've been an academic, the more I realize that I don't care what the institution says. If we're not taking what we're learning and applying it to the real world and reaching people who need that information and that we can learn from, I don't think we're doing our job. I really don't. I think that is a central ethical mandate that we should all be following. It's not popular a lot of times. I mean, I have colleagues who look at an op-ed I've written in the LA Times and they're like, why are you doing that? I don't know, because a few million people read it, and this article will maybe get 100 readers over the lifetime. I mean, I think there's a role for both of those things. But our public voice is very, very important, I think. So.
I would appreciate it if you talk some about the project you've done looking at breast cancer in homeless population and kind of how that came to be and what you've learned from that.
Right. So this would have been around maybe 2010. Not sure of the date. I was in my office and went to my mailbox, and there was a newsletter there from a local church called Church of the Reconciler. How it got there, I have no idea. I think somebody was just delivering them to mailboxes. But Church of the Reconciler is a Methodist church, but the primary population it serves is homeless folks, men and women. And in that newsletter, there was a small article about, I think, 3 members of that congregation who were homeless, who also had experienced cancer. And it was a little bit about their trials, and I think it may have been asking for a donation to help them and for rides and that kind of thing. And I realized, like I have many, many times, that okay, I'm a lot more privileged than I realized, because it had never dawned on me that people who are undergoing cancer treatment are living on the streets. So I picked up the phone, I called the church, got a hold of an associate pastor by the name of Rachel Martin, and I went down the next day and I started meeting the men and women who had been diagnosed. I ended up interviewing maybe 9 or 10 of those individuals. From a publication standpoint, I wrote an article for a consumer magazine that's targeting breast cancer advocates and survivors and caregivers. But and then I ended up developing a program called Street Smarts, through which homeless women in particular are brought together. This has kind of ceased since COVID, obviously. And it's a program where we provide lunch to them. We provide information about cancers. It began with breast cancer, but we extended it to include skin cancer, cervical cancer, etc. And then when they leave the event, they take with them a backpack that they can carry on the streets. And the backpack has a message about, being aware of your body and changes in your body. And the backpack is filled with all kinds of kind of feel-good products. So lotions and sunscreen and a bottle of water and fruit and, soap and toothbrushes and toothpaste and that kind of thing. So the idea is that for so many of these women, they're coming from abusive backgrounds. In fact, a lot of the women actually don't even want to share their name when they walk in the door. We just assign them a number. They don't want to be seen. They don't want someone who, maybe they're running from to see them. But for them to feel nurtured and to realize that someone cares about them. And, we're lucky in Birmingham because although Cooper Green is kind of fading away floor by floor, it does still offer services to individuals who can't afford most medical services. So it's not as though we're informing these women and then saying, well, good luck finding somebody who will care for you. There is a place where they can go and get care. So the stories were unbelievable. There was one man who was schizophrenic. His name's Charles, and he had colorectal cancer. He's still alive, actually, but he would go to Kirkland Clinic, get treatment, and then go sleep under a bridge. And knowing how you feel after chemo, that was so hard to understand. One of the women, Edwyna, is still a very good friend of mine. She lived with a lump in her breast for 6 years before she finally thought maybe she ought to have somebody look at it. And I asked her one time, I said, Edwyna, why did you wait? Your mother died of cancer, you had kind of been around it. And she said, well, in my house, if you go to the hospital, it's a one-way trip. If you go to the hospital, you're not coming home from the hospital, you're gonna die there. So she just kept putting it off. She didn't want to go to see what was going on. Despite the aggressiveness of the cancer, it was triple negative when she finally got the diagnosis, she's still alive. She's just a few months younger than I am. And I can say the difference in the accessibility she has to services, and even, I think the concern and care surrounding her cancer diagnosis is night and day from mine. I've had to go with her on occasion to the doctor when she's requesting pain medication, because there are sometimes physicians who assume that she's not really in pain. And she does have a background of, drug addiction. But they also monitor her. She does urine tests, and so they can figure out whether or not she's abusing the drugs. But it's a different world. So, one of my pet peeves is that there's a parallel here to farming, actually. Let me talk about farming for a second. So, I'm the 5th generation of a farm family. And my father, growing up, actually worked on the farm for many years with his father with mules and, pulling the plows. And I know this for sure because I've seen pictures, but also because when I cleaned out the sheds last summer, I pulled all the stuff out of the shed, 150 years worth of farm equipment. John Deere Company rolled out a new combine just a few months ago. It's just been a few months. It goes for $850,000, and that's without the bells and whistles. So if you put the bells and whistles on it, many of which are needed, it's over $1 million. So many farmers are left asking, who is that for exactly? Who is it, other than big industrial farms, which that's its own, we're not going to go there. Who is this for? And I think to some degree that's happened in healthcare. So, for example, immunotherapy is becoming much more accessible and affordable. But when immunotherapy for cancer first kind of came on the scene, the only people who could afford it were, Jimmy Carter, people who had the funding and the socioeconomic means to afford that. And so I think that, through the Alabama project, which I've also worked on, and with my project or my work with the homeless, I think that one thing that is crystal clear from, immersing yourself in those communities is that we've got amazing health care. The research is fantastic. The pace at which we're learning about cancer and how to treat cancer and how to prevent cancer is astounding and wonderful. But who is it who's getting the advantage of that? When I was diagnosed in 2004, and I'm somebody who keeps up on what's going on, I felt like I was walking into a different world. The whole terrain of what it meant to have cancer and be treated for cancer had changed. There was sentinel node biopsy, for example. So whereas the first time I had cancer, when I was on the operating table, they they removed lymph nodes and they tested them. They removed several lymph nodes. I think they removed 12 or 13. The second time I had cancer, I went in the day before the surgery and was injected with a dye, a kind of glow-in-the-dark dye, so that when they opened me up on the operating table, they could see whether any of my lymph nodes glowed. So they still removed 2 or 3 lymph nodes just to double check. But on my right side, I have complete mobility. I forget that I've even had cancer on the right side. The left side, I still have issues with the number of lymph nodes that were removed. In 1993, it was one doctor at a time. You went from office to office to office. You know, it was, general practitioner who was addressing things. You had your surgeon, you had your plastic surgeon, blah, blah, blah. In 2004, everybody was in the same room. It was a group approach to medicine, a team of doctors. Everything was different. So, again, I'm not saying research is bad, or obviously it's great. The more we know, the better we can do. But to forge ahead without consideration of who is the $1 million combine really for, there are real ethical questions that we have to, absolutely. I mean, there are people who can't afford even the pain medicine they need after surgery, or, and I'm the first to admit, I mean, even knowing the things I know, I'm still in a privileged mindset. I'm a white woman who's educated and who has the means to pay for care and knows what to look for and knows who to call and has transportation. That's a huge issue for a lot of people who are, underserved. They don't even have transportation. Edwyna told me that during the course of her chemo treatments, there was a nurse at Cooper Green who would give her money to take the bus back home, where she, during treatment only, was sleeping on the floor of her sister's house. I mean, we don't think about those things, so.
Talk a little bit about the Alabama Project and what impact that has had.
So I'm really bad with years. I just kind of float through life. But so David J. is he was a fashion photographer, well-known fashion photographer. And many years ago, he started dating a woman, an Australian woman, who was diagnosed with breast cancer. And he saw what she went through. And so he became very interested in what happens aesthetically to women who experience breast cancer. So he took a number of photos, I think he's up to over 100, for a project called the Scar Project. And these are images of women, really just their torso and their faces, from various cultures who have been disfigured in some way because of breast cancer. So at some point, he was actually contacted by someone in Alabama, I honestly to this day don't know who it was, who had a 17-year-old white patient at UAB actually, or knew of a woman at UAB who was 17 who had very, very aggressive breast cancer. So he came to Alabama and he took photos with her permission for the Scar Project, and through kind of the grapevine learned about other young women in Alabama who had breast cancer. And so other than this initial woman that he learned of, all of the other women were African American. And I think, looking back, I think all of the initial women who participated had triple negative breast cancer. It's very common in young women, African American women, and Hispanic women. So he took images of these women, not all for the Scar Project, and realized there was a lot more to their stories that he couldn't capture. So he started looking around for a writer, and we met each other. He interviewed me and some other writers, and he said, "No, you're the one I want." So we started working together. I wrote a number of articles about these women and their experiences, and we created an exhibit of the images, and I wrote the stories that they had communicated with me. And then we decided to expand it. So we ended up going into the Black Belt and brought into the project, the Alabama project, 5 more women. These women were, in most cases, older, had other types of cancer, but again, African American, had very unique stories. And so I would go with David, and he would take photos, and I would interview them, and then I'd write about them. Well, what ended up happening is that the images and the stories were so powerful that we not only displayed them on the walls of the Tumor Institute here at UAB, the Wallace Tumor Institute, where many of them still hang, but we decided to create a traveling exhibit. So the images and the stories have now gone to, in Alabama, they've gone to Huntsville, to Hudson Alpha, and to the Space Center. They've gone to the Freedom Center in Cincinnati. They've gone to the American Association for Cancer Research Annual Convention in Philadelphia. They've gone to the Cardinal Bernardin Cancer Center at Loyola University Medical Center in Chicago. And they've gone somewhere else too, but I can't remember. So they've traveled. And what's happening is that people from different parts of the country are seeing a different face of breast cancer. It's not pink ribbons and balloons. It's having to make a choice between feeding your children in some cases or getting the health care that you need. Of those women, of those 10 women, 4 have now passed away, including Leah, who was the young woman who started the entire project. She died at age 19. And she encountered a similar story to what I started this whole interview with, which is that when she first went to the doctor said, well, you're only 17. I mean, that's not breast cancer. So she was sent away. And that happens a lot. Some of that is due to, this is the rhetorician in me coming into play. It comes from a kind of generalizing definition and understanding of breast cancer. Breast cancer is actually many different diseases, many different kinds of malignancies, different kinds of aggressiveness, from sort of pre-cancer all the way through metastasized cancer. And there are a lot of assumptions, largely fueled by the media and by mainstream messages in a lot of medical institutions. So that when somebody shows up who's really young, or somebody shows up with a cancer that's triple negative, we need to know that those situations are likely to lead to more aggressive growth of the cancer. So, when I was diagnosed in 1993, rhetoricians would call this kairos. It's kind of opportune timing. It's a term that the ancient Greeks used. And at the time I was diagnosed, it was the exact same moment when the pink ribbon movement was beginning. And while the pink ribbon movement has done some good stuff, it's done some really bad stuff too. And that is that it has created a mainstream message that does not include nuances in our understanding about what breast cancer is. It promotes a restitution narrative whereby, at least initially in the early 90s, if you detected your cancer early enough, you'd recover and everything would be fine. Well, we know now that sure, early detection's a good thing, but that's just not true. It depends on the grade of the tumor and, the staging and the exact, etiology of the tumor and all of those kinds of things that nobody took account of. So.
If you think about the messages that you would like to get across to mental health professionals, for example, that are working with survivors of breast cancer, what are the
I think the most important thing, well, two things that are related. I think the most important thing is to strive to understand the individual in her or his entirety. Try to understand the context. It sounds sort of like a silly, misguided point, but it's not really about the cancer. It's not about the cancer. It's about, yes, it's about treating the body and all of that, but what is hurtful that leads to depression, that leads to anxiety, is that your life story and all aspects of that life story have, like that, been changed. And they're not gonna, that's, the old story isn't gonna come back again. So you're treating the entire person. Let the individual tell his or her life story. Let them tell you about their kids. Let them tell you about, when my daughters were young, I had trouble pushing them on swings because my arms were weak. And I mentioned that more than once in visits to my oncologist, and I don't think they even heard it. But that was what living with cancer was. So I think it's listen to these individuals and listen to their stories of cancer in context, because that is where the action is. That's where it matters. I mean, you can talk about, so what number treatment are you on, and how many months do you have left, and are you healing from the surgery? Those things are blips on a screen. What really matters is that kind of lasting revision of the life this individual thought he or she was living and suddenly isn't. You're never the same again. You're never the same again. And until folks get that, medicine, I talk about this with my students all the time, because a lot of my students are either in the healthcare field or they're going in that direction. On the one hand, you want to derive generalities and principles that you can apply to a huge population of patients you're going to see or subjects that you're going to research. But on the other hand, by doing that, we sometimes lose sight of the uniqueness and the nuance of the individual. And there has to be room for both of those things. And the only way you can figure that out is by listening to the patient. If a patient, for example, a survivor, has a symptom that nobody else has reported, it doesn't mean she doesn't have the symptom, right? And so I think that's the message. Listen and recognize nuance. Right.
And as a therapist, potentially help change the way that's going to be perceived.
Right.
As much of a lemonade story as possible.
Yeah, because I think, for example, in my case, and I mean this genuinely, even at 29, I cared very little about the changes to my physical body. It just wasn't. That's not where my head was or where my values were. Even today, I mean, I kind of don't remember what my body looked like before. But for other women, that's huge. I mean, that's a reason to not get treatment, to not have surgery. For me, the big sort of disappointment, I guess, the narrative I didn't want to accept was that I wasn't going to go back to the carefree, I'm invulnerable kind of, I would never be that person again. And it's funny because I think the kind of both vulnerability and strength I have now is unique and was well worth, in some ways, I mean, I hate to say it, but it was kind of well worth the experience. I don't think I'd want that other me now. And I think my daughters have learned from that. My daughters have seen that I don't get hung up about the changes to my body, and that, one thing I say oftentimes to my daughters when they're complaining about, something that I view as trivial, and maybe this is bad parenting, but I say, there are things to be upset about, and there are things that are going to be solved or not, but they're going to go away and they don't matter in the grand scale of things, or the grand scheme of things, and that this is one of those things. Because that's how I view the world. There are real problems that you need to tackle, and there are things that at the end of the day just don't matter. They just don't matter. So, and I think that varies for each individual. The reason I said bad parenting is that I think in some ways that's not for me to say, because to them, what I view as relatively insignificant may be incredibly significant. Right, but it's not world hunger. I mean, it's that you have a zit on your face and you're supposed to be going on a date. I mean, this is not going to shake up the world, right? So they roll eyes and we move on. So anyway. I don't know. I mean, I guess I will give a plug for a program that I think gets it, that I think mental health professionals can learn from. The American Association for Cancer Research, AACR, is an organization that I am very involved in. I write for them. I participate as a mentor when they have their annual meetings. And what they do really well is they have something called a Survivor Scientist Program, SSP. And what that involves is bringing expert cancer researchers and practitioners to the table with advocates and survivors, and they learn each other's language. And it has been, it's been around since, I'm guessing, 2005, 2006, something like that. It's wildly successful. I've been on, grant committees and done work with scientists that I've met through that program. I've worked with other advocates and survivors through that program. And I do think there needs to be more interface like that. I don't think it should be, mental health experts here, survivors here, oh, let's come together for a session. I think there needs to be dialogue across, the airwaves. And I think that's what this program is about. It's a first step. But it's a great model. I mean, they've really done a wonderful job. So, yeah, it's kind of the model program. And it's gone through a lot of transformations over the years. I mean, I've been in on it since the very beginning. But it's a good standard model of what I think, for one thing, what's involved is that survivor advocates go to the meetings and they actually go to the sessions and they're learning the science, and then they have special speakers who come in and explain the science to people who feel lost with it. And that's really important, because I know this from being in the survivor community for many years, that one unfortunate thing is that a lot of times survivors don't really understand the science. So that leads to miscommunication, right? And so anything that can kind of, like for example, I would say if a survivor is meeting with a mental health professional, I think it's important to do sort of what you did earlier in this interview. You actually put a clinical term to whatever it is the individual is talking about. I don't remember what the example was, but you made a comment about, I think, trauma or something that tied in. And I think that kind of meta discourse is really important, because the best way for moving forward, I think, is for each party to understand the other party's language. So, and that would be all I was here that I have left to share. So, okay, thank you. This was great.
Think about this from a personal perspective, but also in a much larger context. It made a difference in many ways.
Thank you. And don't buy any $1 million combines. That's the takeaway message. Yeah. Okay, I'm just saying. Okay. Thanks, Diane.